Good afternoon, ladies and gentlemen. Welcome to the 31st Airlangga webinar conference series, Working Together to Prevent Suicide. My name is Wina, along with my senior Dr. Ahmad Heriana, specialist of pediatrics, and my colleagues Dr. Cordin and Dr. Imran, Rahul, and Arya. We are the organizing committee members of this afternoon's webinar. This webinar is organized by the Faculty of Medicine Universitas Airlangga, Surabaya. Before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Rules for ED accredited certification. Your attendance will be recorded by the Zoom applications. By the end of this seminar, participants are required to fill a questionnaire which the committee will send the link of to the chat box. The certificate will be sent to your registered email address. Rules for Q&A. Use the Q&A box on the middle of your Zoom panel to write your questions. Questions will be sorted and discussed after all lectures have been presented. Thank you for your participation, and we sincerely hope you enjoy this webinar. We will start this event with an opening remark from our beloved host, Dr. Prihastami. Dr. Prihastami, the time is yours.
Thank you very much, Rina. This is very much my pleasure to welcome you all to Surabaya Suicide Update, the second in 2020, working together to prevent suicide, along with Airlangga Webinar Conference Series, the 31st. Ladies and gentlemen, fellow doctors, professors, and all of my colleagues, I am very happy to welcome all of you. More than 300 people registered for this conference, and we are very honored because here we are already joined by Professor Murad. He is the president of the International Association for Suicide Prevention. Welcome, Professor Dr. Murad Musakhan, MBBS, MR Psych, CST, PhD. Good afternoon. Very nice to have you here. And also, I would like to welcome Dr. Sulistiawati. She is the third Vice Dean. On behalf of the Dean, she will be opening this afternoon officially. And also, I would like to welcome Dr. Nalini Muhdi, psychiatrist, consultant in women mental health. She is the Indonesian representative of International Association of Suicide Prevention. And also, Dr. Damba Bestari as the moderator for today. Thank you, Dr. Ahmad Heriana, and also all of the team from the AWCS, Airlangga Webinar Conference Series, for hosting this very lovely Surabaya Suicide Update for 2020. And before we proceed, I would like to ask a moment for us to listen to Hymne Airlangga. ladies and gentlemen, as we know that suicide prevention is not only one person's burden. It's all of us working together to prevent suicide. And to highlight the importance of suicide prevention, please welcome Dr. Sulistiawati. She's the Vice Dean of Airlangga Medical Faculty. The time is yours.
Thank you, Dr. Briastami. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and best regard from our Dean of Medical Faculty Airlangga University, Professor Budi Santoso, Dr. Spesialis Obstetric Gynecology Consultant, and he apologies cannot attend directly on this webinar because he has other activation in the same time. So I ask permission to read opening speech from Dr. Budi Santoso. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore dan salam sejahtera untuk kita semua. Segala puji bagi Allah Subhanahu wa Ta'ala atas berkah dan rahmat-Nya, kita semua masih diberi kesehatan dan kesempatan untuk berkumpul secara virtual dan menghadiri acara webinar Surabaya Suicide Update 2020 dengan tema Working Together to Prevent Suicide. The honorable speaker and participant of this webinar, first of all, I would like to express my sincere gratitude to Head of Department of Psychiatry, Dr. Nalini Muhdi, Spesialis Kedokteran Jiwa Konsultan, VCM, senior and all staff of Department of Psychiatry as well as our colleagues from other department in the General Hospital Dr. Sutomo, Faculty of Medicine, Airlangga University. And our special guest today, Dr. Murad Mosakan, MBBS, MCR Psychiatry, CCST, PhD from Aga Khan University, Pakistan, and University of London. Sejawat sekalian, sebagaimana kita ketahui bahwa kasus bunuh diri merupakan persoalan kesehatan mental yang sangat penting. Berdasarkan data WHO tahun 2016, tingkat kasus bunuh diri di Indonesia menunjukkan 2,2 kematian per 100.000 penduduk untuk wanita. Sedangkan untuk pria 5,2 per 100.000 penduduk. Angka ini cukup tinggi dan mengagetkan tentu saja. WHO juga menyatakan bahwa setiap satu orang yang melakukan bunuh diri terdapat 20 orang yang melakukan percobaan bunuh diri, yang berarti bahwa orang yang mempunyai pikiran atau niat untuk bunuh diri tentu saja jumlahnya lebih besar dari angka tersebut. WHO juga menekankan bahwa bunuh diri merupakan fenomena global yang menjadi penyebab kematian nomor 2 di dunia untuk remaja usia 15 dan sampai 29 tahun. Dan dari data Infodatin, kasusnya dewasa muda ini 5,1 per 100.000. Jadi cukup mengagetkan angka ini. Oleh karena itu, kita sangat perlu memberikan perhatian yang besar pada masalah suicide ini, dan suicide prevention on primary healthcare ini kayaknya sangat penting karena merupakan salah satu strategi untuk mengatasi masalah ini. Oleh karena itu, saya selaku Dekan Fakultas Kedokteran Universitas Airlangga sangat mengapresiasi adanya webinar ini, dan besar harapan saya acara ini dapat menjadi salah satu forum strategis bagi para sejawat sekalian untuk mengupdate ilmu, menambah wawasan, memperluas jejaring, dan tentu saja sangat bermanfaat untuk peningkatan kualitas pelayanan dan menurunkan angka kematian akibat bunuh diri di Indonesia. Semoga webinar ini berjalan lancar, dan dengan mengucapkan Bismillahirrahmanirrahim, acara webinar Surabaya Suicide Update 2020 dengan tema Working Together to Prevent Suicide, secara resmi saya nyatakan dibuka. Akhir kata, terima kasih atas perhatian Bapak dan Ibu sekalian. Wassalamualaikum warahmatullahi wabarakatuh. We hope this webinar success and useful for all participants. And Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you very much, Dr. Sulis, for your concern and also for highlighting the importance of suicide prevention. As we know, the number is shocking for all of us. And it's not just a number, it is someone's loved ones, maybe someone's father, someone's mother, someone's child, someone's beloved. So thank you very much. And we hope that we can do better prevention after this seminar. Thank you very much. Dan Ibu Bapak sekalian, seperti kita tahu bahwa angkanya memang cukup tinggi dan mungkin memang tidak hanya angka, tapi sebenarnya merupakan orang kesayangan dari ayah seseorang atau ibu seseorang, anak seseorang. Dan tidak hanya dokter saja, tidak hanya psikiater saja, kita semua perlu bekerja bersama untuk pencegahan bunuh diri sehingga angkanya lebih kecil. Dan sebelumnya saya ingin mengucapkan juga selamat Hari Dokter Nasional untuk hari ini. Happy National Doctors Day for Indonesia. This is our day, Prof. Murad. So, but not only doctors who are joining us this afternoon, we also have other mental health workers from psychologists and also medical students and also future psychologists. So a lot of people are joining us for today, so we are looking forward to listen to your talk this afternoon. Before we proceed, I would like to introduce our beloved moderator for today, and she will be also presenting ethical aspect, of course, concerning suicide prevention. So I would like to welcome Dr. Damba Bestari. She is a psychiatrist, a very young psychiatrist, but she also a member of International Association for Suicide Prevention. The time is yours, Dr. Damba.
Yeah. Thank you very much, Dr. Brihastami and Dr. Sulis for the opening speech. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, and good morning for Professor Murad Khan, since he's in London and it's still 9 o'clock in the morning in the UK time. Yeah. Before we start with our two speakers today, let me present a little about suicide prevention and ethics, since it's very sensitive. I'll speak in Bahasa, but the PowerPoint will be in English. Please let me share. Yeah. Okay. Sorry. Yeah. Is it clear? Okay, thank you very much. So, I cited this from a journal. Jadi saya mengutip ini dari sebuah jurnal oleh para ahli etik, ya, and it's taken from KWC DLE Advances in Psychiatric Treatment about ethical perspective in suicide prevention. Ya. Bahwa ada sebuah masalah besar dan filosofis dalam hidup ini adalah bunuh diri. Menurut kata-kata Albert Camus, seorang jurnalis sekaligus filsuf terkenal, menjadi sebuah pertanyaan bahwa kalau seorang manusia berhak untuk mempertahankan hidupnya, apakah dia juga berhak untuk mengakhiri hidupnya? Ya. Seorang profesional tenaga kesehatan tentunya memiliki kewajiban untuk menghargai kehidupan sejak awal konsepsi. Kalau ada orang yang ingin bunuh diri atau suicidal, kita sebut, lantas apakah dibiarkan saja? Karena ini kan keputusan dia sendiri yang ingin mati. Apakah seperti itu? Ternyata ada sebuah penelitian dari jurnal ini yang menyebutkan bahwa dari 100 orang yang meninggal karena bunuh diri, 93 orang diantaranya terdiagnosis dengan gangguan mental atau psikiatri. Maka kita bisa menyebutkan bahwa suicidal adalah sebuah gangguan medis, adalah sebuah kondisi medis. Dan dari jurnal ini juga disebutkan bahwa dari penelitian PET scan dan lain-lain juga ditemukan bahwa pada otak manusia yang suicidal, fungsi dalam mengambil keputusan yang rasional itu sangat terganggu. Sehingga ini merupakan suatu kondisi darurat medis, bukan kondisi normal. Maka sama halnya dengan orang yang sesak nafas, dia memiliki gangguan baik di organ, sistemik, atau syaraf pusat sehingga fungsi pernafasannya terganggu. Kita tidak bisa melihat dari sudut pandang orang yang sehat dan bilang, oksigen kan banyak, nafas dong kayak aku. Ya. Itu sama dengan menghakimi orang yang suicidal dengan bilang bahwa hidup kan indah, harusnya kamu bersyukur. Nah, kemudian poin kedua adalah, pada orang yang ingin bunuh diri juga ada kondisi ambivalensi atau konflik. Di satu sisi dia ingin mati, tapi juga ada tetap rasa takut bahwa dia akan mati. Jadi ada konflik. Dia ingin mati, tapi dia juga takut mati. Lalu bagaimana cara membedakan dia serius ingin mati dengan seeking attention atau cari perhatian? Satu hal yang kita semua, saya yakin akan sepakat karena kita semua adalah profesional dan tenaga medis, bahwa prinsip dalam life saving atau menyelamatkan nyawa adalah anggap itu serius sampai terbukti bahwa itu tidak serius. Seperti dalam pandemi COVID ini ya, dalam protokol kesehatan, anggap semua orang itu positif COVID sampai terbukti kalau negatif. Maka intervensi yang sifatnya paternalistik, ya. Mungkin kalau ada yang masih ingat, paternalistik itu adalah salah satu hubungan dokter dan pasien, yaitu hubungan di mana keputusan dalam melakukan suatu tindakan ada sepenuhnya di tangan dokter. Biasanya pada kondisi yang emergency. Maka juga dapat diberlakukan dalam suicide prevention ini, karena suicide, seperti yang tadi sudah saya sampaikan, juga merupakan kondisi medis yang darurat atau emergency. Langsung pada kesimpulan, maka intervensi model paternalistik dalam suicide prevention dibenarkan secara etik. Ya. Dan untuk sebagai pengantar, saya masih ingat kata-kata pembicara Surabaya Suicide Update tahun lalu bahwa kita harus realistis, bahwa tidak semua bunuh diri dapat dicegah, tapi kami percaya bahwa kita bisa melakukan suatu perubahan. Dan kalau bukan oleh kita, siapa lagi? Kalau tidak sekarang, kapan lagi? And how to prevent suicide will be explained by our next speaker, Dr. Nalini Muhdi, psychiatrist consultant. She is the head department of psychiatry in Universitas Airlangga and Dr. Sutomo Hospital. And she is also an Indonesia's national representative for International Association for Suicide Prevention, or as known as IISP. So her presentation is about suicide prevention on primary healthcare. I'll stop sharing this time. So Dr. Nalini Muhdi, please.
Thank you. Just a moment. Yeah. Ininya di ke atasnya bisa. Ini ya. Oke. Okay, thank you, Dr. Damba, as a moderator. Assalamualaikum warahmatullahi wabarakatuh, and welcome my distinguished guest, Professor Murad Khan. Good morning from London time. London time, yeah, London time. Far away from Indonesia, but thank you very much for your coming in the webinar about suicide prevention. And number two, Dr. Sulistiawati, the third dean, the third dean, yeah, from Airlangga University, Faculty of Medicine, yeah. But especially to Prof. Murad Khan, I apologize that my PowerPoint slides will be in Bahasa Indonesia because all participants here are Indonesian. So it will be easier to understand, I think. But I will present the whole contents in English. Thank you. Yeah. Suicide prevention on primary health. Oke. WHO mengatakan bahwa 24 per 100.000 kasus dari suicide di seluruh dunia, tapi tentunya ini adalah data yang sudah harus di renewal karena ini sudah lama ya, tahun 2010 atau 2015 kalau tidak salah ya. Ini adalah di Indonesia 10 per 100.000 penduduk dan itu pun itu sudah lama juga belum diperbarui. Saya sudah minta kepada Health Minister ya bahwa seharusnya sudah ada penelitian baru yaitu 100.000 ini penduduk Jakarta itu melakukan committed suicide itu pada tahun 2006, berarti sudah 14 tahun yang lalu ya. Tentunya sekarang ini jauh melebihi itu, sudah berkali-kali lipat. Dan ini adalah faktor suicide yang berhubungan dengan suicide ya di Indonesia khususnya, yaitu hopelessness ya, putus asa terhadap suatu kondisi, keadaan, kemudian rasa tidak aman ya, banyak hal yang mengakibatkan, kemudian pendidikan yang rendah dan tentu saja low income atau poverty dan insecurity pada saat sekarang ini jauh sangat melambung ya karena adanya pandemi ini nanti yang akan dijelaskan oleh Prof. Murad kan ya. Ketidakpastian tentu itu menyebabkan rasa tidak aman. Di dalam primary care ya individual seringkali mereka itu sudah yang meninggal itu sudah pernah datang ke primary care health center ya. 83% dari mereka yang meninggal karena suicide itu pernah mengunjungi primary care health center di mana 64% itu adalah kunjungan biasa. Yang lainnya 83% itu pada semua dokter ya. Jadi sebetulnya mereka itu sudah pernah datang ke dokter. Ini adalah teori ya di mana effective prevention strategi adalah di primary care khususnya bahwa kita harus melatih staff ya khususnya dokter, psikolog ya dan semuanya ya health workers untuk merecognize, mengenali dan merespon adanya warning sign dari suicide. Kemudian kita merencanakan safety plan atau temporarily restrict means of lethal self-harm. Ini adalah kita menentukan bagaimana membuat si yang calon mau melakukan suicide ini di tempat aman ya dan nyaman, dan kemudian kita bisa meyakinkan bahwa dia tidak mempunyai alat-alat yang bisa dipakai dia untuk melakukan bunuh diri. Selanjutnya adalah melakukan screening untuk memanage depresi, gejala depresi, dan ini sangat penting. Juga screening untuk semua pasien yang mempunyai risiko bunuh diri, dan ini sudah dilakukan justru di negara-negara tetangga, dan di Rumah Sakit Dr. Sutomo sudah kita usulkan bahwa itu semua pasien yang datang ke triase, jadi semua pasien fisik maupun mental itu di screening untuk suicide risk ini tadi, nanti saya bicarakan di belakang. Dan tentu saja di primary care health center, misalnya community health center, puskesmas ya, itu seharusnya juga sudah terlatih dan ada tool yang cukup gampang untuk merupakan suatu deteksi awal. Kemudian mengeduket pasien tentang warning sign of suicide ini, jadi mereka paham. Tentang melatih staff di primary care health center untuk mengenali tentang warning sign of suicide ya. Mereka harus tahu dulu kegunaannya dari untuk melatih itu adalah mereka tahu mereka apa yang dicari dan bagaimana mencarinya, itu juga penting ya. mengobservasi ya dan merespon kalau seandainya ada pasien yang mempunyai warning sign for suicide. Itu nanti saya jelaskan di belakang. Kemudian adalah segera mendetek ya kalau ada pasien yang mempunyai warning sign atau orang yang mempunyai warning sign melakukan suicidal atau mempunyai suicidal ideation. Mengidentifikasi warning sign itu adalah orang-orang yang dalam bahaya melakukan pencederaan diri atau self harm ya, atau self harm adalah bagian dari suicidal behavior itu kepada mereka ya. Kadang-kadang memang harus langsung, kadang-kadang indirect. Jarang pasien itu secara sukarela mengatakan bahwa saya ada pikiran ingin mati atau ingin bunuh diri. Jarang sekali ya, apalagi penduduk Indonesia karena bunuh diri itu adalah masih merupakan suatu stigma ya, dan juga religion ya, semua agama melarang untuk melakukan bunuh diri, sehingga jarang yang dengan seperti di negara barat ya, di western, bahwa orang bisa mengatakan bahwa saya ingin bunuh diri. Kalau di sini jarang. Dan kemudian hati-hati dan awas, waspada terhadap warning sign ya, pada pasien yang betul-betul beresiko tinggi untuk melakukan suicide dalam waktu yang mungkin cepat. Ini adalah strongest warning sign ya. Warning sign yang betul-betul kita harus waspadai, yaitu kalau ada pasien yang dia mengancam untuk melukai atau mau bunuh diri ya, atau dia bilang bahwa dia ingin melukai diri atau membunuh dirinya sendiri. Kita harus betul-betul waspada. Jangan mengatakan bahwa justru di masyarakat ada yang terus kemudian ya sudah mati aja gitu. Itu jangan sampai ya. Kemudian termasuk statement yang mengatakan bahwa keluargaku mungkin lebih baik tidak ada aku. Ya, aku tidak ingin berada di sekitar orang-orang tersebut atau siapapun yang mungkin dia merasa tidak berharga atau justru tidak nyaman. Kemudian dia mencari cara ya untuk mengakses alat-alat yang bisa dipakai untuk bunuh diri. Misalnya umumnya adalah seperti yang di Jakarta barusan ya sebulan lalu, bahwa dia kemudian menggantung diri di atas monumen, di atas jalan layang. Itu sebetulnya dia sudah beberapa lama, dia sering ke situ, dia merenung, melihat gitu. Jadi dia sudah mengobserve means atau alat untuk yang dipakai dia ingin bunuh diri. Termasuk adalah membeli pisau ya. Saya mempunyai pasien di mana dia seorang dokter ya, bahwa dia kalau libur, dia memang orang yang merasa sendiri atau lonely ya. Dia ke pasar dan dia kemudian beli pisau ya. Dia sampai di rumah dan itu saya tanya, itu taruh di kamarnya ya, pisau-pisau itu dijejer gitu. Kemudian dia berbicara atau menulis tentang masalah mati ya, kematian, bunuh diri ya, dan itu tidak biasa dilakukan. Ini seperti dulu terjadi pada seorang mahasiswa di sebuah universitas ternama di Surabaya, bahwa sebetulnya sebelum dia meninggal, dia sudah meninggalkan suatu suicidal note ya, bahwa dia bicara di SMS bahwa saya mau pergi jauh, jangan cari saya, kepada teman dekatnya, teman-teman dekatnya. Tapi teman-teman dekatnya tidak aware ya terhadap perkataannya itu. Sehingga akhirnya padahal dia orang yang sangat religius. Sehingga kemudian besoknya ditemukan dia menggantung diri di tangga fakultasnya. Jadi hati-hati betul-betul. Ini merupakan suatu strongest warning signs. Dan di antara orang tua, mereka seringkali mengatakan bahwa saya tidak ingin menjadi beban orang lain. Saya nggak mau jadi beban untuk anak saya. atau saya tidak punya siapa-siapa lagi. Hati-hati, bahwa itu juga merupakan suatu simbolik ya. Belum tentu, tapi itu sudah merupakan simbol dalam hal ini. Ini adalah warning sign yang lain ya, di mana ada hopelessness, anxiety dan sebagainya ini, dan merasa terjebak ya, tidak ada jalan keluar lagi. Ini adalah other warning sign dari suicide. Screening untuk memanage depresi ini penting, yaitu melatih provider dalam hal ini mental health workers ya, termasuk psikolog, untuk mengenali dan men-treat depression ya. Tapi kalau ini menyangkut prescription dari antidepresan atau yang lain, tentu itu bekerja sama. Ada suatu kolaborasi antara psikiater, psikolog dan social worker dan sebagainya ya, tenaga kesehatan yang lain. Dan paling efektif adalah kalau kita bisa mendiagnosis dan memanage depresi itu sudah merupakan suatu langkah untuk mereduce suicide rate ya, atau suicidal behavior. Screening semua pasien untuk suicide rate seperti yang saya katakan tadi ya, bahwa men-screening itu adalah sesuatu yang sangat penting ya, pada pasien, semua pasien fisik maupun pasien mental. Itu di screening tentang suicide risk. Ada 9 kalau set ya, memakai, nanti saya jelaskan di belakang ya, bahwa pasien juga seringkali kalau dia menunjukkan ada warning sign, sebaiknya ditanya secara reguler ya tentang suicidal thought pada yang ada pada mereka, di mana ada intensitasnya yang mungkin up and down. Kemudian memakai suatu screening ini ya, 9 item depression scale of the patient health questionnaire, dan itu sangat cukup efektif ya. Ada yang lain lagi. Ini adalah yang patient health questionnaire dalam bahasa sudah di bahasa Indonesia kan ya sebetulnya. Ini kurang berminat atau bergairah dalam melakukan apapun, merasa murung, sedih, putus asa, atau sulit tidur, mudah terbangun, tidur, merasa lelah, kurang bertenaga, kurang nafsu makan, terlalu banyak makan, dan sebagainya. Nanti bisa dibaca sendiri, dan ini ada skornya yang masing-masing ada berat ringan dari skor tersebut. Ini adalah arti klinisnya ya dari skor tersebut, yang kemudian nanti rekomendasi terapinya ada di sebelah kanan. Kemudian ini adalah yang dipakai di Rumah Sakit Dr. Sutomo, yaitu ini adalah pertama kali kita mengusulkannya pada saat akreditasi GCI tahun lalu ya, setahun lalu lebih, 1,5 tahun yang lalu. Set person, di mana set person ini dipakai seharusnya bukan di ruangan atau ward semata, tapi di triase, di emergency admission ya. Semua pasien atau di poli, semua di baik fisik maupun psikis itu ditanya tentang set person, dan ini digunakan di Malaysia dan juga di Singapura. Di hampir tiap rumah sakit, dan ini suatu langkah maju, dan Dr. Sutomo sudah menganut ini juga karena untuk lebih gampang ya, di mana set person ini ada suatu skor yang bisa dilakukan bahkan oleh perawat ya, yang dilatih gampang sekali, atau bidan atau tenaga kesehatan yang lain. Oke. Suicidal ideation itu sangat luas dan sangat sangat berat gitu ya, di mana pasien itu punya pengalaman ada ide suicide yang datang terus menerus atau kronik, dan kemudian kadang-kadang pada saat akut stres itu ada suatu pikiran suicide ya, di mana ini akan berdampak ya. Kita harus memahami hal ini bahwa ini adalah suatu kegawatan, apalagi yang di sebelah kanan itu ya. Suatu kegawatan yang dapat berdampak pada masa depan baik pasien maupun masyarakat ya. Ya, ini adalah menanyakan secara langsung tentang pikiran bunuh diri atau menghentikan kehidupan. Jadi sebetulnya orang ingin bunuh diri itu bukan ingin mati, tapi lebih kepada ingin menghentikan kehidupan atau stop the painful life ya. Dan ini kita berikan screening untuk itu. Dan kita mengeduket atau mendidik pasien atau orang-orang yang pernah melakukan bunuh diri ya, untuk dia tahu warning sign ini dan segera menghubungi mental health workers ya, bahwa ada yang strongest warning sign seperti saya katakan tadi ya, kemudian ada yang ditambah dengan warning sign dari suicide yang lain ini nanti. Jadi kalau dia sudah bisa berani mengatakan bahwa saya rasanya pengen mati saja dok, itu untuk di Indonesia itu adalah sesuatu yang sebetulnya sudah merupakan kondisi extraordinary ya. Karena apa? Kita berhadapan dengan social culture, stigma, dan juga religion. Sehingga kalau dia sudah mengatakan saya ingin mati saja, itu berarti sudah overburden, sudah overwhelmed. Dan kemudian dia juga mencari alat-alat untuk bunuh diri, ya. Apakah itu api, ya, tali, pistol, tablet, dan sebagainya, ya. Pil, dan dia mengatakan bahwa dia sudah hopeless, ya, tidak ada alasan lagi untuk hidup. Safety plan itu dan melarang atau memotong dia mendapatkan alat untuk bunuh diri itu penting ya. Safety planning ini adalah crisis response plan, di mana ini sangat bermanfaat dan harus merupakan hal yang harus dipikirkan oleh mental health worker semuanya ya, di primary care maupun profesional yang misalnya psikiatris. Temporary restricting means of lethal self-harm di Indonesia belum ada sesuatu pelarangan untuk mempunyai misalnya kalau di India atau di Sri Lanka itu membeli insektisida itu sangat dibatasi dan dicatat ya, tercatat. Tapi kalau di sini di semua supermarket semua tersedia ya. Mau baygon rasa strawberry atau vanilla ada semuanya ya. Jenis-jenisnya banyak sekali dan itu dijual bebas, padahal itu seharusnya ada restriksi. Bahkan membeli sianida itu konon katanya bisa lewat online shop ya. Itu sangat berbahaya dan seharusnya memang pemerintah atau government sudah mulai memikirkan hal ini karena ini akan berjalan makin meningkat. Komponen kunci untuk suatu risk assessment dari suicide itu adalah kita harus melakukan assessment, yaitu warning sign dan adanya resiko, faktor resiko seperti saya katakan tadi, tapi nanti saya katakan lagi, saya jelaskan lagi. Kemudian apakah dia punya protective factor, kita harus assess. Kemudian kita mungkin harus menganamnesa suicide ya, apakah dia ada pikiran, rencana, atau akses kepada benda-benda yang bisa dipakai untuk suicide. Misalnya seperti yang saya katakan tadi, seorang dokter yang dia setiap minggu, setiap sebulan sekali khusus dia ke pasar untuk membeli peso-peso baru. Karena dia memang ada pikiran untuk suicidal thought gitu tadi. Dan kemudian kita melakukan diagnosa atau clinical judgment. Ini adalah faktor resiko dari suicide kalau seseorang itu menderita gangguan mental, kemudian gangguan fisik, atau sebelumnya dia pernah melakukan percobaan bunuh diri. Dikatakan bahwa orang yang pernah melakukan percobaan diri itu 100 kali punya potensi untuk melakukan bunuh diri kembali dibanding masyarakat atau orang yang individu yang tidak pernah melakukan suicide attempt. Dan ini adalah merupakan suatu catatan buat kita bahwa kalau seseorang pernah melakukan bunuh diri, jadi kecenderungannya melakukan bunuh diri lagi itu besar 100 kali. Kemudian ada suatu negatif life event, ya, apakah dia kematian orang yang dicintai, kehilangan pekerjaan yang sangat dicintai dan sebagainya. Kemudian childhood abuse, ya, child abuse dan neglect, ya. Kemudian pernah lihat seseorang yang melakukan suicide, apakah itu keluarganya, serumah dan sebagainya, tetangganya, itu juga merupakan risk factor. Kemudian LGBT, ya, orang-orang dengan orientasi seksual, ya, sejenis, itu juga merupakan risk factor. Laki-laki lebih banyak daripada perempuan, meskipun yang melakukan attempt atau suicidal attempt itu lebih banyak perempuan, tapi yang completed suicide itu lebih banyak pada laki-laki, jadi yang meninggal. Kemudian ada riwayat keluarga yang mengalami gangguan psikiatri, severe depression, ya. Kemudian ada rasa hopelessness, penggunaan nafsa, kecemasan, dan ada personality disorder. Ya, jadi jangan sampai kita menyepelekan atau memudahkan masalah. Kalau ada orang yang mengatakan saya pengen mati, pengen bunuh diri, itu apalagi sudah berkali-kali, itu hanya sekedar attention seeking atau hanya cari perhatian. Cobalah diajak bicara, kita kasih bantuan, kita kasih harapan dan recovery. Mungkin memang perlu dia diperbaiki dalam hal coping mekanismenya, tapi jangan abaikan. Protective factor untuk suicide itu adalah ketika ada suatu tanggung jawab pada keluarga, apakah dia kepala keluarga ataukah yang paling banyak adalah dia punya anak, ya. Punya anak itu ternyata adalah merupakan suatu protective factor, ya, having child. Social support belongingness, ya, kalau kita merasa menjadi orang yang menjadi bagian dari suatu society, ya, apakah kita dibutuhkan oleh lingkungan kita, oleh pasien kita, atau oleh siapapun, ya, walaupun itu hanya salah satu. Kemudian problem solving skill atau coping skill-nya, ya, apakah dia ada life satisfaction, ya, jadi konsep di kita adalah orang yang bersyukur. Kemudian coping skill-nya bagaimana? Strong therapeutic relationship with a trusted provider. Apakah dia mempunyai seorang terapis atau sahabat yang dekat, yang tempat dia bisa mencurahkan hal-hal yang rahasia, ya. Kemudian ini adalah penting, religious faith. Dan di Indonesia kita berhadapan dengan religion, kadang-kadang ini juga menjadi suatu faktor yang menjadi hambatan, ya. Karena bisa dikatakan atau stigma bahwa orang yang melakukan bunuh diri, oh kamu nggak punya, mau mati, kamu tuh kayak nggak percaya sama Tuhan, nggak beriman, kamu berdosa dan sebagainya. Ya, ini pernah dikatakan oleh, jadi tidak bisa menjadi salah satu faktor. I think, ya, however, as Professor Murad kan one said at the IASP World Congress in Killarney, Southern Ireland, ya, I remembered, ya, that religious faith is not the only single deterrent factor for suicide prevention, even though it has a big role, I think. Ini adalah pertanyaan yang harus ditanyakan ataupun tidak boleh ditanyakan. ini adalah tidak boleh ditanyakan dalam menghadapi orang yang ada pikiran untuk bunuh diri atau rasanya dia ingin mati gitu ya. Sampai kita bertanya, kamu nggak berpikir ya? Ya, saya harap bahwa kamu tidak melakukan itu. Itu baru-baru ini dilakukan oleh saya tahu teman saya ya. Kamu ngapain mau bunuh diri? Sia-sia dosa kamu. Ya. Jangan kamu bunuh diri. Apaan kamu dan sebagainya. Itu adalah pertanyaan yang judgmentally. Ya. Kemudian bagaimana pertanyaan untuk membuka adanya suatu suicidal thinking ya, pikiran tentang kematian pada seseorang. Kita bisa bertanya bahwa sometimes ya orang pada kondisi yang penuh dengan stres itu adalah seperti kamu ini, dia merasa kehilangan harapan. Dan saya ingin tahu apakah kamu mengalami hal yang sama juga? Ya. Atau misalnya adalah apakah kamu pernah berpikir lebih baik mati? Atau mungkin kita bertanyanya adalah dengan kondisi yang penuh dengan stres, nggak punya uang, PHK, saudara ada yang kena pandemi dan sebagainya di dalam kehidupanmu saat ini. Apakah kamu ingin melukai diri sendiri? Atau kamu pernah berpikir untuk bunuh diri? Ini adalah pertanyaan untuk membuka jalan ya. Jadi bukan judgmentally tapi adalah to know ya. Dan ini adalah pertanyaan untuk melakukan assessment apakah dia dulunya pernah melakukan bunuh diri. Apakah kamu pernah melakukan bunuh diri atau mencoba untuk bunuh diri ya. Tapi seandainya bahwa dalam wawancara tersebut tidak ada bukti atau evidence untuk dia pernah mempunyai suatu ide bunuh diri dan kita merasa bahwa memang dia bisa dipercaya, maka kita harus berhenti untuk bertanya dan itu kita catat dalam suatu dokumen atau file kesehatan. Tapi kalau dia memang mempunyai suatu pikiran tentang kematian, secara spesifik kita harus kemudian bertanya apakah sering dilakukan ada pikiran seperti itu, ataukah berapa lama itu terjadi, dan kemudian apa yang sudah dilakukan, seberat apa pikiran tersebut, seintens apa. Kalau ini adalah untuk melakukan assessment pada ide suicidal ya. Kapan kamu mulai punya pikiran untuk bunuh diri? How often do you have thoughts of suicide? Ya, sering untuk mempunyai pikiran suicide tersebut. Berapa lama yang terakhir? Seberapa intens keinginan tersebut? Kemudian adalah apa yang paling buruk yang terjadi sehingga ketika kamu memikirkan atau mempunyai ide untuk bunuh diri tersebut. Apa yang kamu lakukan ya ketika mempunyai pikiran tentang kematian tersebut? Apakah itu sering dan sangat lebih intens pada hari ke hari atau minggu ke minggu? Itu adalah untuk melakukan assessment. Kemudian pertanyaan untuk melakukan assessment tentang rencana bunuh diri. Kamu punya rencana untuk melakukan pengakhiran hidup ya, atau untuk bunuh diri tersebut, sejauh apa kamu punya rencana? Apa yang kamu mau kerjakan? Di mana mau dikerjakan? Jadi sesuatu pertanyaan yang bukan interrogatif tapi empatik ya. Do you have apakah kamu mempunyai alat-alat untuk mau melakukan untuk bisa digunakan untuk bunuh diri tersebut, yaitu tadi yang seperti saya katakan punya koleksi pisau ya, kemudian obat-obatan. Ada pasien saya yang kemudian menelan 30 obat psikotropik ya, dan kemudian dan baru-baru ini juga ada seorang dokter yang meminum pestisida juga ya, dan kemudian terjadi committed suicide di pendidikan ya, atau punya tali ya, dan di mana itu diletakkan sekarang. Kalau yang pisau itu bahkan pasien saya mengatakan bahwa ditaruh di dekat tempat tidurnya, pisau-pisau itu dijejer. Dan apakah kamu punya timeline atau waktu untuk mengakhiri kehidupan ini, yaitu bunuh diri tersebut? Sudah punya rencana kapan mau dilakukan? Dan apa ya kira-kira yang men-trigger atau mencetuskan hal itu? Kemudian untuk melakukan assessment tentang keparahannya adalah apakah hal itu menyelesaikan masalah bila kamu melakukan bunuh diri? Apakah kamu merasa itu bahwa kamu adalah beban untuk orang lain? Kemudian adalah apakah hal itu kamu akan merasa lebih baik kalau misalnya jadi dia kontak dengan keluarganya atau memakai nafsa dan sebagainya, apakah itu merasa lebih baik, atau kontak dengan sahabatnya ya, dan apa yang merasa dia paling banyak pikiran-pikiran ingin mati itu datang? Apakah ketika sedang sendirian, kemudian dia berpikir tentang situasi yang ada sekarang ini, aku nggak punya uang, aku di PHK, aku nggak bisa kemana-mana dan sebagainya ya. Kemudian seperti apa kamu berpikir untuk melaksanakan rencana tersebut? Kemudian apa yang membuat kamu tidak jadi melakukan bunuh diri? Safety plan. Safety plan itu adalah menolong di mana ini adalah think someone may having thought of suicide ya. Tanyakan secara langsung bagaimana kamu kita. Jadi ini adalah untuk provider yaitu mental health worker ya. Bagaimana kita mengintroduce atau memulai berbicara tentang masalah suicide itu. Jangan pada orang Indonesia tentunya kita tidak bisa mengatakan kamu pernah punya pikiran bunuh diri nggak, mau bunuh diri nggak, tentunya tidak seperti itu ya. Kita mempunyai suatu cara dalam hal ini yang lebih halus ya. Misalnya ini adalah yang nomor 3, what are the word you would use ya. Misalnya adalah kalau saya biasanya mengatakan bahwa ini di luar masalah benar atau salah. Pernah nggak ada pikiran lebih baik mati? Saya tidak pernah mengatakan memakai kata bunuh diri pada waktu pertama kali, karena bunuh diri itu masih stigmatized ya. Tapi lebih pada pernah nggak ada terlintas rasanya pengen mati? Menyampaikan masalah itu salah atau benar. Terus bagaimana observasi yang kita lakukan itu adalah warning sign atau strongest warning sign tadi seperti saya katakan. Work together to keep the person safe or no ya. Ini adalah untuk mental health workers juga. Bagaimana kita melakukan assessment tentang urgency atau kondisi emergency. Itu sudah saya katakan tadi, sudah saya ceritakan juga ya. Dan bagaimana kita bisa berbicara secara pelan ya, kemudian dengan empati dan tidak judgmentally ya. Itu yang penting. Bagaimana tidak langsung tapi kita secara smooth, kita harus melihat dulu orang tersebut dari budayanya bagaimana, social culture background-nya gimana, religionnya gimana dan sebagainya. Kemudian adalah untuk safety plan-nya, kita mau bagaimanakan? Apakah kita akan temani dia atau mau kita hospitalisasi, ataukah dia kita panggil sahabatnya atau temannya dan keluarganya dan sebagainya. Ini adalah kita work together ya untuk person safe ya, yaitu siapa yang akan melakukan untuk safety plan ini. Dan kemudian ini memang sesuatu yang susah ya. How long will the plan remain in place for? Ya. Kapan? Mau 2 kali 24 jam atau 1 kali 24 jam atau 10 jam dan dengan siapa ya? Kemudian kalau ada sesuatu kontak emergensinya itu dengan siapa? Itu juga harus kita pikirkan. Dan kemudian kita melengkan mereka dengan profesional, yaitu siapa yang akan kita kontak ya, dengan siapa kita membentuk link ya, dan ini sudah harus dilakukan di Indonesia. Kemudian adalah kalau dia enggan mendapatkan pertolongan bagaimana? Apa yang harus kita lakukan? Itu adalah bagian dari safety plan. Kemudian lingkungan apa kita, dalam lingkungan apa, misalnya puskesmas misalnya atau suatu rumah sakit kecil. Kalau memang kita bisa itu tidak apa-apa, tapi kita harus punya link yang lebih tinggi referralnya ya kalau ada emergency. Kemudian referral to evidence based treatment ya, di mana pasien itu yang mempunyai risiko moderate atau high risk ya, itu harus kita evaluasi dan observasi ya. Kemudian mendapatkan suatu pengobatan baik itu dengan apakah dengan medikasi atau juga dengan psikoterapi tentunya harus ya. Kemudian sekarang ini juga di Indonesia sudah mulai ada telemedicine dan sedikit walaupun tidak banyak ya, sangat sedikit LSM atau grup-grup yang memberikan suatu support termasuk untuk orang-orang yang ada suatu suicide thought. Misalnya adalah saya sebut di sini misalnya halo dokter itu 24 jam, tapi itu hanya untuk dokter umumnya, tapi memang harus kita latih semuanya ya. Kemudian pasien dengan penggunaan nafsa dan ini. Kalau pasien itu membahayakan, dia akan melakukan bunuh diri, tentu harus dengan hospitalisasi. Masuk ke rumah sakit itu adalah as a must ya. Ya. Developing an office protocol for hospitalization ya. Emergency department atau crisis stabilization unit itu adalah mana yang paling dekat dengan lingkungan kita atau rumah sakit atau fasilitas kita, puskesmas kita. Tentunya kalau di Surabaya ada Rumah Sakit Dr. Sutomo, kalau di kota besar juga pasti ada rumah sakit pendidikan. Kemudian transportasi apa? Ini menjadi suatu masalah ya di Indonesia karena tentunya agak kesulitan kita. Kemudian adalah mental health provider yang bisa melakukan asisten untuk mendampingi orang-orang yang memang involuntary harus masuk ke ward psikiatri. Dan kemudian siapa kita bisa mengkontak mental health provider, itu harus mulai kita pikirkan. Dan khususnya ini adalah merupakan suatu masalah ketika di Indonesia bahwa suicide ini adalah suatu hal baru dan belum banyak mental health workers ya, Profesor Murad kan bahwa this is a problem that we still cannot solve in our country. The number of mental health workers is still limited. Budget issues and health facilities and the stakeholder still cannot focus on the priorities. Also suicidal behavior, this is an important issue that suicidal behavior is not covered by health insurance, especially government insurance. But I think is all health insurance in Indonesia not covered suicidal behavior. It's the big problem. Yeah. And the last but not least, ya, take care of yourself. Tetap relaksasi, harus punya network, teman-teman, sahabat, ya. Kemudian kita harus bisa ada teman di mana kita sharing beban kita juga. Jadi kita tidak bisa bekerja sendirian. Kita harus melalui membentuk atau mempunyai suatu network di mana kita bergantian dan kita bisa mengerjakan hobi kita. Kita masih punya me time, balance work and personal life, dan apa kelemahan kita. Kita harus tahu dan kita harus menjadi orang yang tetap comfortable untuk bicara tentang suicide ya. Dan saya kira kalau di sini sekarang sudah mulai terbuka, sudah tidak menjadi suatu hambatan lagi ya. Tapi kita harus tahu ini dan itu harus tetap kita kerjakan. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Yeah. Thank you very much, Dr. Nalini, for a very insightful presentation. This is very important because so many obstacles of preventing suicide in Indonesia. Namun paling tidak dengan adanya presentasi ini diharapkan paling tidak kita tahu bahwa ada banyak hal yang bisa dilakukan. Baik, setelah ini saya akan will start for Professor Murad on because COVID-19 pandemic increases suicide risk factors and it is affecting the mental health of many people. So the next topic will be suicide prevention and COVID-19, and it will be presented by our honorable guest speaker today, Professor Murad Khan. He's the president of International Association for Suicide Prevention. Before Professor Murad Khan share, I will share a little about him, so you can we all can see his CV. So many achievements, but right now he's a professor of Department Psychiatry in Aga Khan University, Karachi, and also a president of International Association for Suicide Prevention, aka IISP. So I think Professor Murad Khan, the virtual floor is yours, please.
Thank you very much, Demba, and thank you for Dr. Nalini for inviting me, and to the organizers for giving me this opportunity to discuss and share some of my views. I'll just put up the screen.
Yeah. Jadi Prof.
Okay, I hope you can see that. Okay, so what I'm going to be talking today is in the context of this pandemic that is affecting all of us. And I share my views both as a faculty member at the Aga Khan University in Karachi in Pakistan, where I've been for the last 25 years or so after completing my psychiatric training in the UK. And since 2017, I'm also the president of the International Association for Suicide Prevention. So what I'll be saying is related to both these associations and organizations, and want to share my views on this. We're all living in a very difficult time, and it's truly global. So we are all affected, and it is only by coming together that we can deal with this crisis that we have. I will share my views and focus more on suicide prevention and mental health issues related to quarantine. Dr. Nalini has very nicely summarized the clinical risk factors and how to manage people who are suicidal at the clinical level, very comprehensively put. And Dr. Demba has also touched on a very important topic, the ethical perspective of suicide and suicide prevention, because we sometimes overlook these things. So thank you very much for highlighting that. So these are areas that I will try and cover in my presentation. I hope I don't talk for 45 minutes. I think people get bored, and I think it's also very difficult to talk for 45 minutes on a webinar. It seems like you're talking to yourself when you don't have people sitting in a hall. So I'll talk a little bit about COVID-19 and how is it affecting the mental health. What is the role of stress? Stress that is caused internally in our bodies by the virus, but also the stress from many of the external factors that are the result of the pandemic, the consequences of that. And then more particularly about suicidal behavior, what evidence is there that a pandemic increases suicidal behavior? Can we learn from history? Have there been similar incidents in the past that can throw some light as we try and deal with the current situation? And then how do we prevent from people becoming mentally ill, suicidal, and going on to die by suicide? What are the challenges? What do we need as a community, as a society, both national as well as at the global level to prevent this from escalating and taking a toll on us? So these are some of the areas that I'll cover. Hopefully, if I don't, then if I leave time for question and answers, we can always discuss that. So this COVID-19 creates a perfect storm, really, as far as health issues are concerned. It is a situation where the communicable and the non-communicable diseases have come together and collided in this massive problem that we have on our hands. Most of the world so far has been focused more on the communicable diseases, and non-communicable diseases of mental health has been ignored largely. It is only now in many of the developed countries that non-communicable diseases, NCDs, are being given as importance. However, many of the lower and middle income countries, like my country, Pakistan, like Indonesia, and so many others, are still struggling to overcome the communicable diseases. And that's where all the money, the resources, the training, the health services are geared towards: treating infections, treating diarrhea in children, treating respiratory infections, and so on. And non-communicable diseases like cancer, like hypertension, like diabetes is not given that much importance, and mental health in the non-communicable diseases comes right at the bottom. Very few countries actually invest in mental health, but now, because of this pandemic, it is really a perfect storm where you cannot separate non-communicable and communicable. It is really creating this problem where you have to address both these issues together. So we know that the pandemic has wrought havoc all over the world. Last night, before I went to sleep, I looked at CNN, and there were globally more than 42 million cases, and it's rising. Deaths globally have been more than 1.1 million, and it is expected, the modeling that people have been doing, that by January 2021, which is only about 3 months, 4 months from now, this number will more than double, and 2.5 million are expected to die by, it's a hard but a very tragic fact. And I hope either the vaccine is developed before that, or people take the kind of precautions that governments are putting out and adhere to them. I'm here in the UK. I've been I came here for work, but I got delayed, and we are hit by the second wave now. And the government messages have been very confusing. They still don't mandate the mask. It is very voluntary, and even places like shops and public transport where you're supposed to wear a mask, a lot of people are not doing that. So this issue about freedom of choice of individual rights is really coming into focus now. Of if you allow people to behave like that in a situation where their own behavior affects the other people, then this is being seriously questioned in Western democracies, as opposed to China, which is criticized for its authoritarian rule. But look how they contained it and have continued to manage the cases that have been there. So I think it's not just the health, but the whole socio-political system really has to be shaken up to see where we are going as a race. The pandemic has created a mass traumatic event. It is not a one-time, it's evolving, it's still going on, and people are predicting it may be with us for a very long time, even after the vaccine has been developed. So it's taking a toll on us physically, emotionally, psychologically. It's creating these huge challenges that we are ill prepared to deal with. Indonesia, I was looking at the figures on the net last night again, and it's not such a pleasant picture. So you cannot be complacent. You have almost 400,000 death cases and more than 13,000 deaths. Obviously, it's much better than many of the countries. In the UK where I am, the death rates are about 45,000 so far. We've all seen what is happening in the US and India. So definitely Indonesia is much better in many ways, but not completely free. So there's no time for complacency. We know that any kind of stress or life trauma affects us all. In this pandemic, we've seen the economic fallout of the pandemic. There's been massive job loss in all countries. There's been an economic downturn. The global economy is going to shrink. This is going to cause mass upheaval everywhere. People who are living already on the edge, like in Pakistan, a country of 220 million people, 50% live under or around the poverty line. So the pandemic has had a major impact on them because most of these people who are poor are daily wage earners. So every time there's a lockdown, they lose their livelihood. And I'm pretty sure it's the same in many other low and middle income countries. There's this question of social isolation. Because you may actually pass it on. You may not have the illness, but you may pass it on to your elderly parents, grandparents, and so on. So social isolation has become a huge problem. We have to isolate not only from family, but from friends, from work colleagues, and so on. There is decreased community and religious support. Churches and mosques are now closed in many parts of the world because of the risk. And so when people derive support from these places, they are denied that. And one has to be constantly on the lookout that you're not very close to somebody. If someone's wearing a mask, you have to maintain the distance, you have to wash your hands. You've got to wash your hands before you take off the mask and so on. So all these new procedures is raising an anxiety level. It's not easy to be on vigilance constantly. So you really cannot lower down your guard. If you were to touch a handle of a public place, for example, in a public setting, and then you would touch your mask, you have the danger, you don't know who else has touched that. You have the danger of transmitting it to yourself. So this constant vigilance is taking a huge mental health toll on us. And then services have been disrupted, particularly mental health services. People who had contact with their health provider, mental health provider, are disrupted. Many people are not linked to the internet to have telemedicine or online. So it's again creating a huge problem, particularly in settings where the resources are limited. Now, when I said this is a perfect storm of communicable and non-communicable diseases, the COVID-19 is actually creating this response. So there is a biological stress response. Once the virus enters the body and it unleashes this massive immune and inflammatory reaction, this cytokine storm that happens in the brain that is causing the problem. It affects many bodily organs. It's affecting the heart, the liver, the kidneys, and so on. And we know now from people who have survived of that, many people have symptoms that go on for many weeks and months now. When the first cases started coming in late December or early January, it's 10 months now. So people who have recovered are not fully back to the baseline. So we know that many organs are affected, and some of them might be affected permanently. We don't know. Enough time has not gone, but it is taking quite a toll. And from this leads to lowering down of our mental health. Mental health is compromised. For example, both from the biological aspects, but also from the environmental aspects. And the study done in USA showed that depressive symptoms have increased 3 times in the general population than what it was before the pandemic. Now, the brain is a unique organ in the sense that it is very protected and it is hard to reach. The blood-brain barrier protects us naturally from many pathogens. But it is also extremely sensitive to changes in the environment, because that is what the brain's core function is, to detect the changes and then to respond, prepare the body, and then to respond in an appropriate way. So that is what the brain does. And when the brain is attacked in the manner that it is being attacked now, then sometimes it gets overwhelmed. So the brain is a very important function, has a very important function in this COVID situation. Now, whenever there is a stress of any kind, any trauma, any stress, there are multiple neurobiological systems that are activated through hormones, norepinephrine, adrenaline, for example. The cortisol is released, neurotransmitters, endorphins or serotonin or dopamine, growth factors are released. There is an inflammatory immune process that are again activated. And now more and more people are looking at the gut microbiota and how it is affected to our levels of a mood state. So there's a lot of research going on in this area. So any kind of stress will affect all of these things, and that brings about changes within our body. And the body then has to adapt to this new change, and it either fights the threat or the trauma that it is faced with as the body is prepared, or it flies away, it runs away from that threat if the threat is very difficult, the so-called fight or flight response. If one was to, for both fight and flight, the sympathetic nervous system is activated, and once the threat is removed and the body starts to relax, then the parasympathetic system starts to kick in. So stresses are many different types, but when they are very intense or they are chronic. Intense is like what we are facing now. Suddenly you find that you've been tested positive and you start getting symptoms, your breathing becomes bad, and that's a very intense stress. Or chronic, like a bad relationship, a bad marriage, or a job in which you're not satisfied. It's low grade, but it's chronic. So both of these things will affect our immune system and our stress response. And there is what is called an allostatic overload, where the body cannot cope and the body then breaks down. But even very severe transient stresses, like what we are facing nowadays, sensitizes the body so that once the stress is removed, next time the same stress comes in, although it may be minor or transient, we may, or the body may overreact. So it's very important to understand what we are going through now. And although we may come out of this, we might be sensitized for future reactions, future stresses, future such situations. And therefore, dealing with this in a constructive and a positive and a healthy way is extremely important. Now, the brain, as we know, has nerve cells and various chemicals, and what we experience, what we perceive, what we comprehend is then converted into what the mind does. And the mind, as we know, is related more to thoughts, feelings, attitude, beliefs, memories, imagination, everything which is abstract. And any kind of stressful event will affect all these neuronal processes, both from the brain and the way the mind then comprehends and perceives all of these different things. And if they don't do it in a sustained and a constructive manner, it will lead to a lot of psychiatric and neurodegenerative condition. And therefore, it's extremely important to understand that in this area, we don't have enough good treatments. So it is extremely important to focus our efforts also on prevention strategies, both for mental health, both for suicide prevention. There are no medications that are totally effective, say for treating depression, for example. We know many patients don't respond to medications, whether they're antipsychotics or antidepressants. And therefore, we have to focus, while we also look to develop services to treat them, also to look at how do we prevent these things from happening in the first place. Like I said earlier, COVID survivors, we are now seeing that they have elevated suicide risk. They have a lot of anxiety, depression from the fear of becoming too ill, having to be hospitalized. And those patients who have been hospitalized, either in the general wards or on the ICU, and what they undergo is terrible. Some of them have survived after many days in the ICU, and they've written about it. And if you read some of the some of the experiences, it is really quite shocking. So it starts from just learning about the diagnosis of COVID. You test yourself, you don't have any symptoms, but you are positive, and then suddenly this fear that will I become symptomatic? Will I have these symptoms or not? People are coming on the television and describing what they go through. For example, people are saying the breathing becomes so difficult, it's like you're drowning and you can't breathe. Just and try to swim, have any little in the kind of feeling they have. So when the people describe that and others listen to that, it creates this fear once they come out to be positive. This fear of infecting others. And then there are direct symptoms of the illness, like weakness, for example, breathlessness, and so on. And like I said, if you're hospitalized or if you're unfortunate enough to get into the ICU and then you're ventilated, then it has its own trauma. And obviously there are other external issues like loss of income, for example, staying at home, working from home. We know that domestic violence has increased because so many people are now staying at home. It has caused a lot of tension. People are not used to working at home. Some of these people who don't have enough space are finding it difficult to share the same space with others. In China, an early study that they'd done, almost 100% of the patients who had recovered had significant post-traumatic symptoms, they had flashback, that anxiety, that insomnia, and this fear of falling ill again. So that's a huge number. So it's not something that people can very easily overcome. And then there are direct neurological effects. And when it affects the brain, obviously it will affect some of mental functions also. It has led to ischemic stroke, headache, dizziness, ataxia, in some cases seizures. About 25% of patients have this symptoms, neurological symptoms. And many patients are now ending up with weakness and pain, kind of myositis, pain in generalized pain, which is not limited to any one particular part. All of these compromise mental health and therefore increases the suicide risk. Now, any kind of infectious disease which is large scale leads to public health emergencies, and there is a question whether it also increases the suicide rates or not. And there is some evidence from the past that mass events, mass catastrophic events, whether it's a tsunami or world war or earthquakes, do impact mental health as well as suicide rates. And there is the hypothesis that this pandemic may also increase suicide rates. So can we learn from history? Can past pandemics give us any clue of what is happening now and what is likely to happen now? So this is one of the earliest pandemics that has been recorded. This was between 1889 and 1893. So this was the Russian influenza that came out of Russia and then pervaded the Europe as well as the United Kingdom. In the United Kingdom, they had records, so they recorded it. And the epidemic coincided with a marked rise in suicide rates. So obviously they were tracking suicide rates from before 1889. And in these 4 years, they found that suicide rates had increased. So although the direct relationship with the pandemic at that time, or the epidemic at that time, was not so well established, but there was definitely a new factor that had been introduced into the community, and suicide rates had gone up. And the peak of the suicide rate in the UK was 8.5 per 100,000. So the theory was that because this thing had invaded the UK, it was a new environmental risk factor that had been introduced. This was responsible for the increase in suicide rate. The second pandemic that happened was between 1918 and 1920, and then there was a second wave also. And this was just towards the end of the First World War. Just imagine coming out of the First World War and then being hit by this pandemic. And what it showed is, in the graph, you can see these two peaks. So this is the mortality rates, and this line below is the suicide rate. So there was a small increase in suicide rates during the pandemic. But obviously mortality rates were much, much higher, mortality from the actual pandemic. But this is another indication that in time, so before 1918, 1920, suicide rates were lower, and then there was an increase. Now, one may argue that even in the past, the suicide rates were higher, as you can see here. Before this happened, for 4-5 years before it, the suicide was much low, and then suddenly increased. So there was an increase in the suicide rates. This is obviously going back 100 years. More recently was the SARS epidemic in Southeast Asia. And the study that was done in Hong Kong showed that because of the SARS epidemic almost 20 years ago, it was associated with an increased risk of completed suicide in the elderly, but it was more in the female elderly rather than in the males or the population under 65 years of age. So in Hong Kong, female who were elderly over the age of 65 had higher suicide rate during the period of the SARS epidemic. So this was the third one. What is happening now, we don't know. I think data is being collected, and perhaps in a year or two, we might be able to see from countries that have good surveillance system, or whether there was an increase in this time of change in the suicide rates. Now, while the pandemic may increase the suicide rate, and this is what is being hypothesized, and that is why a number of articles are now coming out to see how to deal with that, it is also possible that because of the way we live nowadays, the connectedness we have with the social media, WhatsApp and Instagram and Facebook, and obviously the cell phone, we might actually be more connected. And so because of this connection, we may not be physically connected, but at least we are connected abstractly. We can call people all the time and talk to them, look at them, and so on. So it might actually lead to decrease in suicide rates, or at least suicide rates may not increase. So this might actually be protective against suicide, and this might be because of the availability of the internet, which was not available maybe 30 years ago, or when the SARS epidemic hit. So this is something that we'll have to study and see. But what are the risk factors? We all know, because of prolonged quarantine, where I am, we've gone into the second wave, and again there is a lockdown here. So everyone has to, all the bars and pubs and restaurants are closed again. There's widespread societal fear, not only of the infection, but also of the economic fallout. In the early days, there were a lot of medical equipment shortages, which led to a high degree of anxiety and fear amongst the medical personnel. That has been rectified to a large extent now, as hospitals have geared up and refilled their stocks. However, the health services remain disrupted. Here in the UK, for example, majority of the doctors, including GPs, either do telephone consultation or video consultation. And so many people are not satisfied, particularly the elderly living on their own, have difficulty talking on the telephone, or definitely can't do it on the video. So all of these things are causing compromised mental health, and therefore the risk of suicide is also increasing similarly. And this is how it works out. An article by Leonard Scher this year, that COVID-19 leads to a number of uncertainties, social isolation, economic problems. People who are vulnerable, who either have pre-existing psychiatric disorders, who have low coping mechanisms, low resiliency, or they're living in areas where the COVID prevalence is very high, and therefore they have to take more precautions, or may have a family member who has been either ill or who has actually died of COVID. So all of these people are very vulnerable, and either their pre-existing psychiatric disorders may become exaggerated, or they may develop new conditions of depression or anxiety. Some of them may resort to alcohol and other substances to deal with the problem, which causes secondary problems. And they may have other psychiatric conditions, for example, like psychosis, like OCD, which is causing major upheaval because of the hand washing and so on. So all of these increase the risk factors and therefore make the person more prone towards suicidal behavior. I very quickly want to turn towards what is happening in terms of global suicide, not just related to the pandemic, but generally. About 800,000 people die by suicide every year around the world. This number has come down a little bit from 1 million people that used to be there. So that's a good thing. Global rates are now, it used to be 16 per 100,000. It has come down to just under 11, 10 and a half per 100,000. Again, a very good and a positive sign. But it still remains the 5th leading cause of death worldwide and in the young people. And I was reading again on the net about Indonesia, and it's not just Indonesia, many other countries, is the young people in whom the suicide rates are going up. And that's why it becomes more worrying, because the younger the person who dies, the greater there is loss, not only to the family, but to the society. More than 75%, in fact, 80% of suicides happen in low and middle income countries like Pakistan and Indonesia. And only 30%, 20 to 30% happen in high income countries. And in Asia itself, 60% of the world's suicides happen only in Asia. Obviously, Asia is the largest continent. It has got 2 countries, India and China, which have populations over 1 billion people. So you would expect the number of suicide to be higher, but nevertheless, Asia has the largest proportion of suicides. This is the map that we all are familiar with. The ones in the dark red are the ones that have very high suicide rates, include Russia and the former Soviet Union countries, and then obviously you have US, and the yellow one, or the dark yellow, are the countries of South America and Africa, and then you have the light yellow, which are many of the Islamic countries, including Indonesia, including Pakistan. But these are estimates for these countries because we do not have good national surveillance systems. So WHO estimates for these, and some of these estimates may actually be quite wrong. So like I said, if you look at the trends over the last almost 30 years, total deaths have increased, but the age standardized mortality rate has decreased. And like I said, from 16.6 to 11.1 or 10.5 nowadays. Rates for men are always higher than for women, except in countries like Bangladesh and China, and India, which is 1 to 1. And in all countries, in all regions of the world, the rates of the men remain high suicide rates remain high for men than for women. These are the countries with high suicide rates. And you can see there are countries from Russia, but also Africa, as well as the Caribbean. Suriname is in Caribbean. And the lower star, you can see that 4 of these are Islamic countries. And this is a Caribbean country. But again, some of these countries don't collect good national data, so we don't know how accurate this is. Changes in suicide rates is quite remarkable. And the most dramatic fall has been in China, almost 65%. But other European countries have also shown a decrease in suicide rates. And that is because of not only investment in mental health, but also of the socioeconomic changes that have taken place. On the other hand, you can see other countries have increased suicide rate, like Zimbabwe, which is going through a severe economic crisis for many years now, and a country like Zambia and Belize. Funny thing is, in the US, suicide rates before the pandemic was rising. They usually had about 35,000 deaths by suicide every year. It's gone up to 47, 48,000 deaths. And the worrying thing is now with the pandemic, this may increase further. And this is the US, despite all the wealth and the investment in mental health that they have. This is the UK. Again, suicide rate had been consistently falling over the last 30, 40 years, but over the last 2-3 years, it has again shown an increase. Now, the lesson here is that you cannot be complacent in suicide prevention. You cannot let your guard down. You have to keep on chipping away. You have to be constantly vigilant and invest in suicide prevention. This is Indonesia. So it's very good that suicide rates have actually been coming down generally in Indonesia over the years. I hope this data is accurate, but it will be very interesting to see what has happened since then, particularly over the last 3-4 years, and now since in 2020 and going forward, will the suicide rates increase or not? It's still worrying because in Indonesia, I was reading again yesterday, there are 7,000 to 10,000 suicides, and majority of them are in young people. The decrease in China's suicide rates has been very dramatic, and the people are looking at what may be the factors. It might be the amazing economic growth, the urbanization, which has led to improved standards of living and better access to medical care in rural areas, but also because pesticide poisoning was used very commonly in China, it might be because these are now better controlled. So all of these factors may be affecting the suicide rates in China. When we talk of suicide prevention, then we are talking of 3 different areas. I mean, you can talk of suicide prevention from many different angles. This is a simple framework. You can either have suicide prevention strategies that are universal, that affect the whole population. For example, you want to bring down unemployment and you want to create more jobs. So that is a universal suicide prevention strategy, because we know unemployment is related to increased suicide rates, or you address poverty. So that becomes a universal. Selective is specific subgroups of people. For example, people who are suffering from depression, children who are bullied at school. So these will be specific and they're selected population, and you address suicide prevention strategies to this subgroup. And indicated would be people who are already exhibiting symptoms of suicide. So for example, someone who has made a suicide attempt, someone who's expressing suicidal ideation, then these are indicated prevention. And for all of these, the approach has to be slightly different. And a good suicide prevention strategy will have all of these 3 elements, not just universal, but not just indicated, but all of these 3. So in terms of COVID-19, using this approach, what can we do as a universal approach? Well, there's a lot of fear, anxiety, that people are isolated now, and how do we address that? So media can be used to promote mental health, to reduce the distress, but they have to do it in a consistent and a responsible manner. And media reporting in many countries is not very good. And nowadays with the social media, all sorts of myths, misconception, rumors are put up there, and people start believing that. So this becomes a huge problem, and we know social media is not regulated at all. But staying connected with the loved ones, with the family, friends, work colleagues is very important. Taking care of ourselves, like Dr. Nalini also said, about sleep, diet, exercise. Know in your neighborhood if there are any people who are isolated, the elderly living alone. Maybe it's not such a big problem in Indonesia. It's certainly not a big problem in Pakistan because no elderly lives alone there. But in the UK, it's a huge problem. Very old people in the 80s and 90s living on their own, and they're completely cut off nowadays. Screen for common mental disorders using the techniques that Dr. Nalini has described. Not only for common mental disorders like mild to moderate levels of depression and anxiety, but also for suicidal ideation, again using the proper approach. Helplines are very useful, but they have to be linked with mental health services. And obviously, because of loss of job, loss of financial security, it's extremely important that financial support is given to people. Selective approach will be those who are at increased risk of suicide, who already are showing any kind of psychiatric disorders, who are emotionally distressed, people who are survivors of the COVID-19, frontline healthcare workers. So we have to have programs, we have to have systems in place that can address the mental health issues of these people. People who already have pre-existing psychiatric disorders, is extremely important that this treatment is not disrupted. So arrangements have to be made that they continue to receive medication, they continue to receive support. If they are having counseling or therapy, that should continue and that should not be disrupted. At the very least, as mental health professionals, we should make an attempt to stay in touch with the patients. We should have systems, device systems to stay in touch. I'm in the UK. I've got a very large practice in Karachi, and what I'm doing now is staying in touch with them through WhatsApp, through Skype, and so on. So I'm doing telepsychiatry. And it's also important to limit the news of this pandemic as of course, inform yourself, but not watch it 24 hours. And we should also counsel the patients regarding this. Indicated approach would be those who've already made an attempt or exhibiting suicidal ideation, and then using a special way of dealing with these people. Some of these people who may have made an attempt at home may fear going to the hospital because of exposure to the virus. So it's also important to either offer them help on the telephone, or at least give them enough assurance that even if they come to the health facility, what precautions would be taken, for example, gloves and gowns and face masks and so on. And it's important to follow them up. So this would be the framework that can be used for suicide prevention, looking at the universal, the selective, and the indicated approach. It's very important that whatever we do is guided by evidence. So collecting data in real time as this thing is going on, is unfolding, is extremely important. And in countries that don't have a good surveillance system, it becomes a real problem. But countries already have a good surveillance system, we can actually see if the rates are going up and down. So it's a very good lesson for us to use this opportunity. If we don't have surveillance systems, if we don't even have it in the country, at least in our own health facility or a district or a city, we should really look at establishing this. This is a very good opportunity to do that. And based on that, prevention programs can be devised. This is what WHO recommends as a national suicide prevention strategy, 9 or 10 elements. Surveillance is very important, restrict the means, inform the media of how to present suicide, access to services, training, education, treatment of those who are suicidal, treatment of depression, crisis intervention, people who have made an attempt survived, then how to follow them up, called postvention, raising awareness, decreasing stigma, and a committee or a body that oversees the whole strategy. And this is very important. For any strategy to work, we must have good surveillance system, and many LAMIC countries, low middle income countries, don't have good surveillance system. So you can see the very low are the dark red, and most of these are the low middle income countries. Pakistan does not have it, Indonesia does not have that. And without this good surveillance system, we cannot study patterns. What is going up, what is going down, what age is more, which one is less now, what methods are they using, how do we control those methods? So we do it anecdotally because we feel this is happening, but we don't have good evidence. And therefore, the first step of any good suicide prevention program is setting up a surveillance system. So the recommendations nowadays for the pandemic is increase your virtual connection like we are connecting now. Have this, it's amazing. I'm sitting here in London and 6 hours behind you, but we are talking to each other. Increase the social support, and healthcare delivery has to increase. Increase access to healthcare using all sorts of creative mechanisms to offer help. Government's financial safety nets for those who are unemployed, who have no other means of income, is extremely vital. Nowadays, when people are staying at home, they may have more access to medications, for example, painkillers. So it's extremely important that we restrict that in our homes. We make sure that it's not easily available. And media has such an important part to play nowadays. So it's training of media personnel is extremely important. The good news, obviously, if one can call it good news from all this dark news, is that there's been greater awareness of mental health needs, and mental health care and suicide prevention is being highlighted everywhere, of how people are stressed and how few mental health professionals there are, and we need more, we need to invest more. So that's a very good news for mental health. But we need to also cash in on this. It's no use just talking about it, and once the whole thing subsides, we go back to business as usual. It's extremely important that we start the discussion, lobby the government, lobby our health ministers to show why the manpower in mental health is so low, why there are so few psychiatrists, psychologists, and counselors. and what can we do to increase the numbers. So it's very important to do so now. And the government has to commit, and they can only do that if they have good leadership, good health leadership and good mental health leadership, and to engage all stakeholders. Nowadays, you may have heard of this term called lived experience. These are patients who have undergone psychiatric illnesses, breakdown and so on, and they have been treated. So we need to listen to them also. So when we say stakeholders, it's not just the professionals, but we also need to involve patients who have experienced what living with a mental illness is, and then what they can do to improve the services. And as far as suicide prevention is concerned, it has to be a comprehensive, multi-sectoral strategy. It's not just mental health, but we need education, we need justice, we need law and order, we know social welfare. All of these things have to be involved in suicide prevention and good mental health. So it has to be a multi-sectoral strategy. The problem may be global, suicide happens everywhere, but the solutions always have to be local, and it must be driven by local evidence. So what maybe the more common methods of suicide in Indonesia may be very different from what is happening in Pakistan or what's happened in the US or the UK. So the local evidence becomes absolutely crucial, and that is why you must do research locally, unless you come up with your own evidence. What I found, for example, very important in Pakistan, in the West, marriage is considered as a protective factor against mental health and suicide. In Pakistan, young married Pakistani women are most at risk of mental health, mental illness, as well as suicidal behavior. Young married women. So this was something that we were able to come up through research, years and years of research, and we kept looking at the data, and this was coming out. Because the way the whole marriage is constructed in Pakistan, it puts a lot of stress on the females that leads to compromised mental health and then to suicidal behavior. So it's very important to study local evidence and then base prevention programs on that. And we have to look at it in a much wider context, taking into account the socio-cultural factors, the religious factors, the political factors, the economic systems, as well as the health system. You can't have good mental health system without a good health system. You cannot integrate mental health into primary care unless you have a good primary healthcare system. So I was very glad to listen to this presentation by Dr. Lanini, because Pakistan does not have a good primary healthcare system. So we cannot integrate mental health, because what do you integrate it in? So first we've got to develop primary healthcare. So in summary, COVID-19 has thrown up a huge challenge for us, not in some countries, but globally. Suicide rates may increase. There is evidence from the past pandemics that they may increase. It is also possible, because of a greater connectedness, that perhaps it may not increase so much. Time will tell. But we have to use this time, because of the awareness that is raised around mental health, to set up good mental health care systems and suicide prevention programs. It's extremely important, and that we don't lose this opportunity. And until and unless we have a national strategy at the national level, certainly we will have to develop local strategies also, but it has to be done at a national level, because resources then can be put in, money can also be diverted, funding has to be there. Once you have a national strategy, then you can have local strategies of how to deal with that. So it's extremely important that discussion must go on. We must lobby the government. We must meet, and we must write the newspapers, go on television and talk about that, and keep on chipping away. So despite all the strategies and everything else you may be reading about, remember the number one suicide prevention strategy is connectedness. People kill themselves in isolation. There are very few people who make public specter of themselves, except in this protest suicide. Most people die in isolation, alone, lonely, and they feel they're a burden to the others, and the only way out of the predicament is by killing themselves. So if you're able to connect to others around, and only we know who our friends are, who our family are, who our work colleagues are, and we are able to detect change in them. So keep connecting with them, or even a simple WhatsApp message, how are things, may be enough to take this person out of that suicidal crisis. And so the first line of defense, we may talk of universal factors and selective and indicative factors. The first line of defense is always family, friends, and work colleagues. Remember that, okay? And the number one universal suicide prevention factor is that we must reclaim our humanity. And what do I mean by reclaiming our humanity? Dr. Damba mentioned Albert Camus, a French philosopher, and that quotation that she showed us, which is one of my favorite quotations also. Camus wrote a book called The Plague. In French, it is called the La Peste. In 1947, it was published. 1947, 50 years before, more than 50 years before today, almost 60 years. And in this book, which is set in Algeria, there is a plague very similar to what is happening now, and people are dying and they don't know what is happening. And everyone is confused. And the story is told from the eyes of a doctor who is in the midst of the whole thing. And someone asked this doctor, his name is Dr. Roux, he asked him, how can we get rid of this pandemic, Dr. Roux? How can we control this? And this is what his answer was. It may seem like a ridiculous idea, but the only way to fight the plague is with decency. And what is decency? Decency is sharing, of being compassionate, of being kind to others. It is giving them justice. It is not hating them, but giving them love. Unfortunately, what we are seeing nowadays, globally in the world, there is a huge gap of good global ethical leadership. Look at the largest democracy, or the second largest democracy in the world. What is happening now? The kind of drama that is going on day in and day out, up till the 3rd November. Look what has happened in many European countries. So this is what is happening. But we also have leaders like your neighbor, for example, in New Zealand and in Germany. So this is what we need to do. The plague's biggest lesson, the pandemic's biggest lesson, is that we need to come together. And only by coming together, we can fight not only suicide prevention, but we can also fight the pandemic. So thank you very much for your attention.
Thank you very, very much for the excellent presentation, Prof. Murad. Yeah, and I really agree with your last quote of your last presentation of your slide, because decency, ya, or kebaikan, ya, dengan self-compassion, we can heal the world, yeah, by decency, by to stop this pandemic. Thank you very much for reminding us. Yeah. So yeah, suicide rates indeed increase, but please stay connected and stay safe. So in this case, I think technology helped very much. Yeah. So I think looks like we already have so many questions here. We have 22 questions, but I think I should choose, yeah, because some of your question is actually already answered on the presentation, yeah, on the PowerPoint, yeah. Oke, saya akan membacakan beberapa pertanyaan, tapi mohon maaf, mungkin tidak semuanya karena beberapa pertanyaan sepertinya sudah terjawab di presentasi, ya. Dan ini saya ingin menyampaikan, ini dari Dr. Mia, ya, Dr. Brihastami. Ternyata nanti di akhir akan ada gift atau reward for best questions, ya. Jadi ini mungkin izinkan saya untuk memilih, ya. I'll choose a question. First for the first speaker, I think for Dr. Nalini, ya. I'll read the question. Okay. Ya, ini. Jadi pertanyaan pertama ini sepertinya tadi belum terlalu terjawab, ya, karena memang ini cukup aplikatif, ya. Dari Riksa Sarah Dewi Metina Pasha, ya. Jika sudah ada strongest warning sign suicide, perlukah misalnya partner saya perawat yang ikut pelatihan kesehatan jiwa Kemenkes melakukan evaluasi misal kunjungan rumah atau bagaimana? Sedangkan biasanya anak terbuka pada orang lain, sedangkan saat kami bertanya, mereka cenderung tertutup. Dan ada pula yang orang tuanya acuh atau tidak mendukung, sementara kami biasanya menenangkan, biasanya by WhatsApp. Terima kasih banyak ya untuk Dr. Nalini. So, Prof. Murad, this question about is it important to do the home visit? Yeah, if there is already a strongest warning sign from suicide. Yeah, I think because Dr. Nalini has already explained in her presentation. I think Dr. Nalini, please.
Oke, terima kasih.
Ya.
Ya, saya mau menjawab. Tadi sudah sebetulnya hanya cepat sekali saya bicaranya karena waktu.
Ya.
Sebetulnya sudah ada di dalam suatu bagan tadi bahwa kita harus menanyakan kepada individu yang mau melakukan suicide itu atau ada suicidal thought, bahwa kepada siapa dia paling nyaman, ya. Kita harus bertanya, dia lebih nyaman untuk berbicara dengan siapa. Tentunya kita sendiri juga harus berusaha untuk mempunyai suatu empathetic communication dan juga tidak judgment, sesuatu yang komunikasi yang tidak judgmentally, ya, tidak menghakimi, tidak memarahi, tapi kita paham, kita menjadi seorang good listener, dan kemudian setelah itu tentunya dia baru percaya, trust, ya, karena itu tidak bisa langsung dia begitu percaya sama kita, tapi itu tentu butuh waktu. Dan jadilah seorang yang menjadi pendengar yang baik. Good listener berarti kita tidak bicara apa-apa dulu untuk sementara waktu, tapi lebih mengarahkan dan dia menjawab, dia bisa mengungkapkan apa yang katarsis, ya, dia mengungkapkan apa yang dirasakan. Tapi yang jelas adalah kita juga bertanya pada individu tersebut, siapa yang dia rasa paling nyaman dan dia merasa aman untuk didampingi oleh siapa, untuk berbicara dengan siapa. Tapi saya setuju sangat sekali, connectedness itu sangat penting. Dan di Amerika sendiri, seorang individu yang punya suicidal thought, ketika dia bisa berkomunikasi dengan orang lain yang empathetik, maka 80% itu bisa ditangguhkan. Gitu. Tapi kalau orang di luar tentu sudah pasti, ketika ada pikiran itu, langsung dia akan mencari suatu kontak, ya, yang dia sudah terbiasa dan biasa. Ini adalah saya lihat di suatu vlog di YouTube, ya, seorang penyanyi jazz dan musisi jazz muda kenamaan Indonesia yang dia memang mempunyai gangguan mood sehingga beberapa kali dia mau melakukan suicidal attempt atau ada suicidal thought, ya. Tapi kemudian ketika dia menelpon, dia melihat di internet mana yang bisa dia hubungi. Ketika dia hubungi, dia dijawab, dan ini adalah rumah sakit jiwa ... di Jakarta, gitu, ya. Kemudian langsung ditutup dia. Dia bilang, gila, saya terhubung dengan rumah sakit jiwa, karena ini adalah sesuatu yang berhubungan dengan stigma, ya. Sehingga akhirnya dia telepon ke Australia, ya. Dia langsung telepon ke Sydney untuk menghubungi suicide hotline service. Saya kira gitu. Tetap adalah kita bertanya pada si individu, kepada siapa dia. Kalau ada kepikiran hal-hal seperti itu, dia merasa comfortable untuk communicate. Oke.
Okay. Thank you, Dr. Nalini. Yeah, thank you very much. So, Prof. Murad, Dr. Nalini answer that we must find the most comfortable person to talk to. Yeah, and sometimes it's very difficult to find that person. Yeah, so I think suicide hotline actually can help, but unfortunately in Indonesia there is no official suicide hotline in here. So I think it becomes a really big problem. Yeah,
just a little.
Just a little. Yeah. Thank you very much, Dr. Nalini, yeah, for the answer. And I think the second question is for Prof. Murad, yeah. This is from, okay, because this is very important. It's about the medicine, I think. Yeah, the medicine. Is there any evidence-based medicine that actually can increase the risk of suicide? Yeah, so is there any medicine in psychiatry or in any medical services, perhaps not a psychiatric medicine, but can increase risk of suicide ideation? Yeah, thank you.
I don't think there is any specific medicine that increases risk of suicide, but certainly there are medicines that can increase depression or that can cause depression. For example, cortisol, for example, can lead to mania, but it can also cause depression at times. Some antihypertensive that is used for blood pressure, including beta blockers, can cause depression. So I don't think there is any specific medicine to increase suicidal ideation, but they can certainly affect mood state or depression, and that can then, if there is a tendency in the person of suicidal ideation, can increase suicidal ideation indirectly.
Thank you very much. So yeah, there is no evidence base. So indirectly, but not directly, I think. Yeah, thank you very much. It's a question from Rizky Setiawan Pramono, yeah. So yeah, there is no nothing. And I think this is also for Prof. Murad, yeah. As we know that COVID-19 is highly affect our mental health as medical workers, especially healthcare workers, yeah. So burnout and so many things. And what can hospital management do in this situation? Is from Zahra Ibadina. Thank you.
It's a very good question.
Yes.
And hospital management must recognize that generally medicine is a very highly stressed profession in these times because of the direct threat to the healthcare professional, nurses, doctors, paramedics. The risk is much more heightened, so they're very stressed. So what they have to do is a number of things. One, they must make sure that no one is on duty for too long. So they must have good shifts, not for very long. They must have a safe space where they can meet after a shift or before a shift to talk and share the experiences. So it's kind of a support group. And some people who become stressed, for example, or are not coming to work because the families are objecting, they must be able to access counseling services for these people. Patients, many doctors may be facing patients who are dying more than what they usually do. So more patients may be dying because of the COVID in ICUs, for example, which is very highly stressed. So it's extremely important to make sure that these doctors not only have time and space to talk about these and share with the others, but also have a counselor to go to if they want to. So some hospitals have actually started this, and they've created a kind of a support group where doctors can come and talk about the experiences, and just sharing some of these things become extremely important. So it is very important for management to not ignore this and to make this available for all their healthcare staff.
Thank you very much, Prof. Murad. I think it's the answer, yeah, Dr. Zahra. Yeah, so I think we need time to relax. Yeah, so not full time, and then there's a support group who can help. Thank you very much, Prof. Murad. Okay, and then the next question is actually for Dr. Nalini, ya, from Alsa Viera. Izin bertanya, sejauh apa batasan kita untuk membantu pasien yang sudah berulang kali menyatakan ide bunuh diri? Apa berhak untuk langsung melaporkan ke pihak yang bisa membantu dia? Jadi mungkin ini otonominya, ya, otonomi seorang pasien itu apakah karena ini kan kondisi yang darurat, ya. Jadi apa kita berhak untuk langsung melaporkan ke pihak yang sekiranya bisa membantu dia, atau kita tetap harus menunggu kesediaan dia untuk dibantu? So I think it's about the question is about the autonomy, yeah, of the patient who is suicidal. Is it okay to to directly link them to professional without their consent. Yeah, thank you. Yeah, Dr. Nali, please.
Pertanyaan untuk saya ya.
Yeah.
Oke, jadi tadi sudah saya sebutkan kita harus apa yang harus kita lakukan kalau pasien reluctant terhadap to get help, gitu ya, untuk mendapatkan bantuan atau pertolongan. Karena pada awal-awal di Indonesia umumnya pasien tidak ingin untuk datang ke rumah sakit. Tapi paling tidak kalau dia reluctant, dia enggan untuk mencari pertolongan, kita harus melakukan suatu assessment. Apakah itu suatu strongest warning sign ataukah sekedar warning sign biasa, common warning sign. Tapi kalau itu strongest warning sign, maka ada yang dikatakan sebagai suatu dia harus hospitalisasi involuntary atau voluntary. Dan kalau memang diperlukan karena itu membahayakan, maka involuntary. Jadi tapi di Indonesia itu masih lumayan ya, karena tidak seperti di negara maju bahwa kalau involuntary patient itu harus kita sebagai psikiaternya harus berhadapan dengan pertanyaan dari Komnas HAM atau di sana biasanya di bawah apa itu Kementerian apa itu kalau di sini hukum dan HAM ya, itu kita psikiater biasanya akan ditanya-tanya tentang kenapa kok memasukkan pasien ke rumah sakit. Tapi kalau di sini kan tidak seperti itu. Tapi kita harus, kalau memang itu adalah emergency, maka itu berarti sifatnya involunter. Dan kita harus yang pertama kali adalah mencari caregiver yang paling dekat, apakah itu family, ataukah itu friend, ataukah ya siapapun yang bisa menghubungi. Tapi kalau itu sifatnya tidak emergency, tetap kita tawarkan dan dia mendapatkan untuk mendapatkan suatu bantuan. Disitulah mental health workers harus mulai membuka diri bahwa kita adalah sahabat masyarakat. Dan yang kedua adalah jadi kita tidak duduk jadi bukan hanya menjadi suatu clinician, duduk di rumah sakit atau di praktek tanpa kita mampu menjemput masalah pasien, masalah masyarakat. Kita harus terjun dan kita harus dekat dengan mereka, paling tidak memberikan rasa nyaman. Dan untuk pertama kali kalau memang itu bukan emergency, mau nggak mau kita harus menjadi kontak person, bersedia untuk menjadi kontak person untuk sementara waktu. Tapi sekali lagi kita juga punya boundaries ya, punya batas-batas bahwa ada hal-hal yang tidak bisa kita lakukan sendirian, harus suatu teamwork dan ya ini ada hal-hal yang dimana dia harus mendapatkan penanganan mental health worker yang lebih intens dalam hal ini di rumah sakit kalau perlu, bila perlu. Jadi tetap harus ada kita menghargai dan menghormati otonomi dari patient.
Ya, ya, thank you very much, Dr. Nalini. Terima kasih banyak, Dr. Nalini, atas jawabannya. Ya, langsung ke pertanyaan selanjutnya. The next question is for Prof. Murad. So it's from Nima Satih Amandita. Okay. Good evening. The COVID survivors tend to have anxiety, depression, or PTSD after they recovered. What can we do as doctors who treat them in the isolation ward to prevent that happen? Thank you very much. Yeah, this is very important questions because, well, in the isolation ward, I think it must be very depressive. Please, Prof. Murad.
Yeah, so the assessment is very important to really talk to the patients. And when I say talk, it's really listening to their anxieties. What are they fearing more? Whether it's about the condition, about death, about the family. So it's important to listen to them and then to obviously reassure them as much as possible. And if they're having symptoms that is interfering with the sleep, for example, or the ability to concentrate, to then get some specialist advice of if they require any medication to deal with the anxiety. And if for example, they feel isolated, they can't talk to the families because the families cannot visit, then what can be done to connect them? So talk to them, listen to them, inquire about their anxiety levels. If it is very high and it's fit with their diet, sleep, concentration, to get some advice from the mental health professionals about use of medications. Short-term benzodiazepines or SSRIs could be used perhaps. And then if they're feeling isolated and not connected to the family, then what can be done to connect with them? And so obviously reassurance, telling them honestly what their medical condition is, sharing the test results, giving them hope will help allay some of the anxiety. So the most important thing from the clinician's point of view, apart from the medications and so on, is good communication with these patients.
Okay. Thank you, Prof. Murad, for the answer. Yeah, I think that's the best strategy to prevent mental illness in people in isolation ward. Yeah, thank you. Okay, so the next question I think is for Dr. Nalini, yeah, because it's about pregnant women, yeah, and I think Dr. Nalini is also a consultant in women's mental health. So the question is about dari Ratih Manggarsari ya. Jadi saat ada ibu hamil yang memiliki tendensi suicide, apakah perlu dirujuk pada poli kejiwaan rumah sakit, dan apakah mungkin ada langkah yang agak berbeda untuk orang-orang dengan kehamilan? Ya, terima kasih. Monggo, Dr. Nalini.
Ya, terima kasih. Tentunya kita harus menghubungi caregiver-nya dulu. Bagaimana? Apakah dia punya suami? Apakah dia punya keluarga, punya ibu terutama? Ini adalah the most important caregiver is mother, her mother. Itu adalah penting harus kita tanyakan. Karena tentu suatu healthy relationship dengan ibunya itu yang paling membuat suatu dukungan bagi ibu hamil. Dan juga yang kedua adalah suami justru, ya. Tapi tentu dalam kapasitas normal, ya, hubungan yang normal dan sehat. Apakah dia harus dihospitalisasi ketika dia ada pikiran bunuh diri? Ya, tentu saja tidak, ya. Tidak. Kita harus bisa mengakses apakah itu suatu dia mempunyai strongest warning sign ataukah custom warning sign, dan juga apakah masih di tingkat ide gitu ya, apakah sudah intens pikiran atau suicidal thought-nya itu harus kita assess dulu. Tapi kalau memang ini adalah seorang dokter di primary health care center, misalnya di puskesmas atau communication di tingkat puskesmas gitu, tentunya lebih baik dirujuk kepada psikiater, ya, terutama karena ini menyangkut nanti penanganannya dengan dokter obgyn, ya, dan gabungan dengan psikiater. Kalau di negara maju itu ada namanya mother and baby unit gitu ya, atau antenatal care gitu, yang itu bekerja sama antara dokter obgyn, ya, dan psikiatris itu, dan psikologis, clinical psychologist, ya, itu juga bergabung dengan pediatrik juga. Itu adalah 4 komponen utama di dalam mother and baby unit klinik atau hospital. Dan yaitu tadi kita harus melakukan assessment dulu. Yang paling bisa mendampingi dia adalah caregiver yang paling penting dulu, ibu dan suaminya atau orang sahabatnya yang dia merasa paling nyaman. Tentu saja kalau itu suicidal thought itu sudah berkali-kali, tentu saja penanganan dari profesional yaitu psikiater sangat-sangat perlu. Apakah di hospital atau di klinik, private clinic, it's okay. Kasih. Nggak ada suaranya.
Okay, I'm sorry. Yeah, thank you very much, Dr. Nalini. Yeah, for the answer. Yeah, I think two more questions. Yeah. So sorry, we have so many questions, but I think we have limited time as well. So I think the next one is from Ratih Manggarsari and please wait and yeah. Ini selain Ratih Manggarsari juga ada yang beberapa yang tanya tentang ini, jadi saya jadikan satu ya. It's about the suicide hotline. I think Prof. Murad perhaps can help to answer this, because in Indonesia we don't have the suicide hotlines. And from your experience, can you please tell us how to make a procedure or a proposal about suicide hotline to the government? And if there is no suicide hotline in Indonesia, can we access perhaps a foreign or international suicide hotline, which is free and available, perhaps at least for some of us who can speak English quite well? Yeah, thank you. Prof. Murad, please.
Yeah, so it's a very good question about helplines. You see, helpline on their own have got limited usefulness unless and until they are also linked to mental health services. So, for example, if you receive a call on the helpline that this person is very suicidal and he or she wants to take this poison or jump off the roof, and they are far distance from where you are sitting, and you don't know what the health services are, what the police services are, how can you help that person except to talk to them and say something to them? So helplines are useful because in a suicidal crisis, they can actually help avert the act, but they must be linked to mental health services where the patient can go and seek help if they need admission, for example, if they need mental health assessment, for example. So that would be very important. So yes, they do have usefulness. In the UK, for example, the most well-known helpline is the Samaritans, and the international arm is called the Befrienders International, and they are in many countries. Maybe not in Indonesia, but certainly in places like India and Hong Kong, they are there. So yes, people can access them. And for those who are not in an acute crisis situation, they can be useful because they can talk to them and they can give them advice. But those who are in suicidal crisis and they either are actively suicidal or they're threatening to do something, I think it'll be very important for someone, say, sitting in the UK, listening to someone in Indonesia of what to do in terms of helping them access services. So what you can do really is to first study, say, for example, in your city, what are the mental health services? Make a map of those services, list them. So many services available. What are the emergency mental health services if the person needs to seek emergency mental health? Once you have made a list of all of these things, you've documented them, mapped the services, then you can think of starting a mental health helpline or a suicide prevention helpline. And there are various ways to do that. It can be a toll-free number if you get funding, so it's free to the caller, or it may be charged one. Most of these numbers are free, so that they encourage people to talk, and you need either a good funding source or from the government who funds it, and then you can start. So my advice would be to first study, look at the experience of other countries, particularly countries which are low and middle income countries. A very good example is my friend in India, Dr. Vijay Kumar, Lakshmi Vijay Kumar. In Chennai, she runs a mental health GO called Sneha, and they have a suicide prevention helpline as well. So look at the model and see how you can apply it there. But you must look at the local mental scene first, and then perhaps start a helpline. And sometimes if you are in a hospital like the university psychiatry department, they can start that for limited hours, say for example, 8 hours a day. We see how it goes, and then you extend the hours, and then you make it 24 hours and so on. But obviously it requires a lot of thought, a lot of planning, a lot of training, and like I said, linking it up to the mental health services. But it has very useful function as part of the overall suicide prevention strategy.
Okay, yeah. Thank you very much, Prof. Murad. So we can access it globally, internationally, even from Indonesia. Yeah, wow,
Yes,
cool.
yes, you can.
Yeah, thank you very much. I think it is very important because so many people ask, how can we reach the suicide hotline, because there is no suicide hotline in Indonesia, and they think that international suicide hotline is not accessible for people in Indonesia. But yeah, thank you very much. So there are several suicide hotlines that accessible globally, yeah, internationally. Okay, thank you.
Good news.
Yeah, it's very good news for people who ask about that. Yeah, and then last but not least, I'm really sorry for all. Mohon maaf untuk seluruh peserta ya. Ini pertanyaannya banyak sekali dan bagus-bagus, tapi mungkin saya akan pilih yang banyak juga yang menanyakan. Ini pertanyaan terakhir, yaitu tentang telemedicine ya. It's actually for Prof. Murad and Dr. Nalini ya. So it's about the telemedicine and telepsychiatry from Novelita Mesa ya. In this pandemic era, there are many things that are difficult for us to do if we do not meet face to face. So how to optimize the diagnosis and management of suicide prevention by telepsychiatry in this pandemic era? Please, Professor Murad, perhaps you have a little point to answer this.
So I agree with you. It is difficult. I was very much against telepsychiatry because I felt in psychiatry, in psychology, face-to-face contact with the patient is very important, because non-verbal communication in mental health is as important as verbal communication. However, we've had to make changes. We've had to adapt. I've had to adapt. And I think although it is not the same as the face-to-face consultation, video consultation definitely gives a much better feel of a real live face-to-face consultation than just a telephone. So there will be limitations. You will have limited picture on the screen. You cannot see the whole person. But nevertheless, I think if we get used to it, it will become easier. We have to look at things like eye contact, for example. You know, if I look at the picture of the person, then my eyes are looking down. If I look at the camera, then that person can see us. So these are little nuances that we have to get used to. Then obviously the issues of connectedness. How do you do that? Then confidentiality, is the line secure or not? Can someone hack into that? So these are some technical issues, but also from the doctor-patient relationship issue, there will always be some challenges. But I would suggest to everyone to try it and to see how it works. It is very tiring, I can tell you this. So make sure that you space the patients enough. So you see a patient, say, for 20 minutes or half an hour, give yourself 5 minutes in between patients to write notes, to just relax, to get up and move around and so on. And try. And the more you try, the better you'll become. You'll become better at it.
Thank you, Prof. Murad. Yeah. So just try, because yeah, at least you try, and it's I think it's much better than just don't do anything. Yeah. So your best effort, I think it's the best one. Ya. Mungkin Dr. Nalini bisa mau menambahkan untuk telemedicine ini, karena kita cukup melakukan telemedicine.
Ya, saya kira sama. Cuman satu kalimat saja jawaban saya. Daripada tidak ada rotan, akar pun jadi.
Ya.
The best thing among the worst, ya. Jadi daripada tidak, ya lebih baik itu.
Yeah. Thank you very much. Then not at all. I think it's better to try. Okay, even it's limited. Okay, thank you very much for all the participants for your question. Very, very nice questions ya. Tapi ini kami memang harus memilih ya. The best questions hanya 3. Mungkin saya atau Dr. Brihastami yang mengumumkan. Saya saja mungkin ya, karena masih di sini. Baik. Ini ada 3 yang sudah kami pilih ya dengan Dr. Brihastami. 3 pemenang untuk pertanyaan terbaik adalah dari Riksa Sarah Dewi, kemudian Zahra Ibadina Silmi, dan Nyimas Ratih Amandita. Ya, oke. Bagi yang tadi yang sudah terpilih ya, tepuk tangan ya. Those 3 questions, ya. Big applause for you all. Ya, I think you can the AWCS team, or you can contact us to have the reward for your best questions ya. Silakan bisa menghubungi kami untuk mengambil hadiah dari best question itu. Baik, ya terima kasih sekali lagi, selamat ya untuk semuanya. So I think to sum up this today's excellent event ya. Thank you very much for Prof. Murad Khan, thank you very much. Akhirnya bisa bertemu lagi ya. Mungkin kalau yang belum tahu, tahun lalu kami sebetulnya ingin mengundang Prof. Murad, tapi beliau berhalangan ya. So I think thank you very much for Prof. Murad, because we're really happy to have you in this webinar. Yeah, stay safe and stay healthy, Prof. Murad. Yeah, and Dr. Nalini, and of course all participants for becoming very active. Thank you very much also for tim AWCS ya, Dr. Boy, Mbak Wina dan tim ya. Dan tentunya last but not least for Dr. Utari Dani, psikiater sebagai ketua acara ini. Terima kasih banyak sudah bekerja keras untuk mengadakan acara ini ya. Saya harap kita semua mendapatkan hal baik dari webinar kali ini, dan satu hal yang ingin saya sampaikan bahwa tolong sebarkan dan praktikkan semua hal baik kepada orang lain agar lebih banyak nyawa yang tertolong. Seperti kata-katanya Marshall FP, bahwa di dunia ini ada banyak orang baik, tapi kita butuh lebih banyak lagi. So I wish you all a very good evening and good afternoon for Prof. Murad. Yeah, I'll give it back to our beautiful host, Dr. Brihastami, please.
Thank you very much, Dr. Donna, as our lovely moderator for this afternoon. And I couldn't agree more with our moderator, because I think this COVID pandemic might be a blessing in disguise, because we finally have Dr. Prof. Murad as our lecturer for today. So it was really nice to listen to your talk, and also Dr. Nalini, and for the discussion. And I could not get a better summary from Dr. Damba. That was excellent. And because she said to spread it more, so I would like to remind all of the winners for the best questions untuk menghubungi Ibu Silvi, panitia atas nama Ibu Silvi, untuk konfirmasi alamat sehingga kami dapat mengirimkan, dan nanti kalau sudah sampai ke alamat masing-masing bisa foto dan disebarkan di sosial media masing-masing ya, supaya orang semakin aware dengan suicide prevention dan Surabaya Suicide Update. Dan tentunya saya ingin pamit undur diri. Sebelumnya kami ingin mengucapkan terima kasih sekali lagi untuk seluruh jajaran dekanat dari Fakultas Kedokteran Universitas Airlangga. Of course, Prof. Murad, thank you very much. Dr. Nalini as our head of department in psychiatry department. And also Dr. Damba Bestari. And also, of course, for Dr. Utari Diahkusumawardani and team as the committee for this year's Surabaya Suicide Update. And also all of the team from the AWCS. And of course, from Singenta as well, who are here today. Vicky and Peter, thank you for coming. And also tentunya kepada seluruh hadirin, guru besar, senior, rekan sejawat, dan juga calon dokter, calon psikolog, dan juga teman-teman psikolog yang sudah hadir pada sore hari ini. Kami harap acara hari ini bermanfaat buat kita semua. Tentunya acara ini juga tidak akan terjalan dengan baik tanpa dukungan Dr. Boy dan juga Dr. Asra dari AWCS. Begitu, semoga kita semua dapat memanfaatkan dan mengaplikasikan ilmu yang kita dapat pada sore hari ini. Akhir kata, terima kasih atas kebersamaannya. Sampai bertemu di Surabaya Suicide Update 2021 tahun depan. We're still working together to prevent suicide. Bye. Untuk seluruh pemateri dan juga moderator, for all the speaker and also the moderator, we're going to take a picture together. So please do not turn off your video yet, because you're going to take a picture under Dr. Boy's command.
Okay. Raul, are you ready?
Ada Dr. Asra. Selamat sore, Dr. Asra.
Ya, baik, kepada seluruh panelis dan pembicara bisa dinyalakan videonya. Izin spotlight semuanya dulu.
Luar biasa ya, pertanyaannya banyak banget. Baru kali ini loh webinar itu pertanyaan sampai 30. Nggak pernah ada pertanyaan sampai 30, banyak banget.
Alhamdulillah, ini PR-nya banyak sebenarnya ya kalau mau dijawab.
Nanti ada rekapnya, nanti kami bikin reportnya. Jadi nanti pertanyaan itu semua bisa dijawab. Bisa didapat. Nanti kami kirimkan ke dokter.
Baik, dokter dan profesor. Dalam hitungan ketiga. 1, 2, 3.
Assalamualaikum. Thank you, Prof. Murad, for your coming.
Prof. Murad, if you're willing to answer all of the unanswered questions through email, we will forward their questions through your email if it's okay. If you have time to answer it through emails.
Ya. Terima kasih, Dokter.
I'll be very happy to answer the questions. Do send them, translate them into English, and do send them to me. Yes.
Okay. Dr. Dona will do it for you then.
Okay.
Thank you.
Oke, nanti
Thank you.
Dokter
Thank you
dibantu
very
sama
Boy, ya.
Wina. Nanti Wina yang akan collect itunya semua saya berikan ke Wina. Nanti biar Wina yang menyerahkan ke panitia.
Baik.
Terima kasih, Dokter.
Oke, mohon maaf
Tim
apabila
AWCS.
terima kasih atas kepercayaannya kepada AWCS.
Ya.
Di sini hadir ketua kami Dr. Asra. Thank you Dr.
Oh,
Asra
ya.
supportnya.
Terima kasih.
Terima kasih semuanya. Assalamualaikum.
Ya, assalamualaikum. Bye bye. See ya.
See ya. 1, 2, 3.
Oke, Raul, saya tutup ya.
Siap, Dokter Boy. Terima kasih banyak, Dokter.
Oke, 3, 2, 1, and